I just wanted to start the show by giving a shout out to someone who just made George's day. So unfortunately, I wasn't recording when George told me this story, but he was visiting a family member in hospital in New South Wales, and he went up to the front desk and was explaining who he was here to see and wanting to know what room to go and see this family member. And the person working there was like, "Oh, are you George from the Pulse podcast?" It just made George's day. We love it when people come up to us and recognize us from the show. We put a lot of time and effort into this podcast, and it's great to get the feedback that you guys are valuing it. So to that woman who is at St. Vinny's, you know who you are. Thank you so much for saying hello to George and to let him know that you really value the show. All right, well, let's get on with the show. Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. This is our Hot Topics show and I'm your host, Louise Shaper.
And I'm your other host, George Margellis.
George, we've been like strangers in the night. We've been at some of the same functions. We've seen each other briefly, but I haven't had a chat to you for a while.
Yeah, look, it's been a pretty hectic couple of weeks since we last had our chat. Things have been pretty interesting. The US excursion in the Middle East led to me spending an extra week in Greece, which could have been worse, but that was lots of fun.
I gather your plane had to be rerouted?
No, so my flight out of Barcelona got cancelled the day beforehand, but fortunately I knew something was happening, so I'd managed to find another flight through Singapore, but it was 4 or 5 days later. For those who aren't aware, a war, null and voids your travel insurance, so you're not covered for cancellations when it's a war. That was an interesting lesson learnt.
Oh, I didn't realise that. I knew it wouldn't cover you if you just actively choose to go into a dangerous territory, but...
No. Yeah, I had a chat to the insurance guys once, and I said, but President Trump said it's an excursion, it's not a war, but they didn't. They said, we declared it a war, so no.
Did you have to pay extra then for the new flight?
I had to buy brand new tickets.
Oh, man.
And I was actually pretty lucky. I managed to get in pretty early and got reasonable priced seats. Other people I spoke to spent 3 or 4 times more than what they normally would pay for a one-way ticket. So It was pretty horrendous.
Yeah.
One of the options for coming back through Barcelona took me home through the United States. It was like a 42-hour trip. And it was about $4,500 one way.
Oh.
It was a pain, but it could have been worse.
Okay.
But other than that, it's been pretty busy. I mean, obviously, I got a chance to see you in person, albeit very shortly in Sydney for the Australian Healthcare Week, which was a fun event. Yeah. It looked like we'd almost planned it when I walked in just as you were announcing the podcast, but that wasn't planned. That was the light rail in Sydney running late. Since the last time we had one of these hot topic calls, I said it was Barcelona. We had the Connected Health Summit there, which was good.
How did that go?
It was really good, actually.
So your picture with Geordie?
I did.
Yeah.
Caught up with Geordie. We attended a dinner and he was on a panel together. A lot of interesting things happening over there. In particular, there's the launches of the Global Health Connectors cancer ecosystem, an international collaboration around cancer research. They had the launch of the Asia Pacific arm of the Global Health Connector, based out of Singapore. We saw a very interesting presentation by a hospital in Singapore, which has replaced wireless Wi-Fi with 5G. And there's lots of discussions around the roles of telcos in healthcare. Now, interestingly, Telstra Health came up a number of times in discussions.
Okay.
By various people from around the world, but I didn't see anyone from Telstra Health there.
Well, that's good news then. They've got advocates.
Absolutely, yeah. Look, there were over 100,000 people there, so they may have snuck past me. But I thought it was strange that a lot of the people came up to me and said, no, Telstra Health was one of the better examples of telcos entering healthcare. We had some interesting discussions around the history of that many of them weren't aware of. Because the MWC, Mobile World Congress, is essentially a telco conference, which has other events associated with it around specific areas. So we did obviously the health part of it, but they're talking about in 2028 having a very major health component. So for people who are planning their diaries, 2028 in Barcelona, there'll be some very major initiatives around healthcare. So that's been my time. And yourself, you've had a fairly quiet couple of weeks, I hear, just sitting around, reading a book.
Yeah, watching a lot of TV, reading a book. Everyone in our industry is always very busy, but I must say my last fortnight has been somewhat insane. I managed to get through it did develop a little bit of a twitch in my eye because I was so tired. I was like, what's going on? And it turned out I just needed sleep. But yeah, I gave like 13 presentations in the space of 2 weeks in multiple cities. It was just insane, but all good. Said goodbye to Charlotte. So we did her final leg of her book tour in Melbourne, and that went really well. She's back home and looking forward to her next trip to Australia. And what else have I done? Oh, the RACGP hackathon, George. 3 days, about 50 people there. It was so big. Greg and I were facilitating and working alongside Mandeep and Sean, Darren, Janice, and the team from RACGP. So good to see the level of commitment to innovation around digital and data for the benefit of general practice and the people that GPs care for. And we had so many good ideas. We couldn't fit them all in. So we ended up having 7 teams, and it was very competitive. It was Friday to start of Friday morning. So Saturday afternoon and mid-afternoon or early afternoon, I'm with a mentor at the hackathon, and we're in this team, and they were really stuck. And I'm like, yeah, that's not a good idea. Like, what else you got? And so they made the very brave decision to pivot. And what they came up with, they didn't win in the end, but it was still a really good idea and got good feedback from the judges. And they spent less than a day to work it through. So a lot of people on Sunday, but looking very tired, but motivated and energized. And yeah, it was a really good event. Really looking forward to next year's. It's great to see the level of passion and commitment by all the doctors there and all the technology people, and of course, our ACGP.
I bumped into Jill Frayne. She told me that it was a really exciting weekend and the stuff happening was really fantastic.
Absolutely. And AWS gave up their venue as part of sponsoring it. And I've never been to their office before. It's awesome.
It's pretty cool, isn't it?
It was really nice. And it was very nice to have all the AWS staff that had to work over the weekend because they're usually not there Saturday and Sunday.
And there's been some interesting announcements by the Australian Digital Health Agency, Louise. You want to talk about those?
Yeah. So, I'm really pleased about that. So, the Digital Health Agency have set up a National Clinical Governance Committee in digital health. And the purpose of that committee is really about guiding Australia's approach to these emerging technologies. So things like virtual care and AI, all the stuff that we need to do to make these things happen, like share by default. So it's really a really significant move. And they asked me to not only be part of the national committee, but we have 3 expert advisory groups. And I'm chairing the one on virtual care and telehealth. Steve Hambleton, who many of our listeners would know, he is chairing the EAG on better and faster access. And we've also have the AI group, and that is being chaired by Raylene Donovan from eHealth Queensland. She's the CCIO there. And like I've got 36-40 people, all representatives of different organisations, and it's a huge cross-section of organisations that I've got in my EAG. So I'm looking forward to what we can do because these groups are really important. Clinical governance,
congratulations,
so critical.
That's a really big step, and it's great to see that the agency setting up the committees, but also recognising that the people who chair them are experts in the field. So well done.
Yes, thank you. My job is to make sure that we work productively and actually come up with advice that will end up, at the end of the day, getting filtered through the agency, and some of it will end up on Mark Butler's desk, the Health Minister. So it's a really privileged position. I'm really pleased to be part of it.
Looking forward to the agency has a big program for 2026, so I'm looking forward to being involved with it.
Yeah, thanks, George. Shall we get to our hot topics?
Let's kick off.
Well, George, we kickstarted the year with a 2-part episode, which I must say has proven very popular. So if you're new to the pod, go back and listen. We did a part 1 and part 2 on what the direct-to-consumer Gen AI products mean for healthcare. Well, in the last fortnight, big tech has continued their march into healthcare. We now have Amazon, Microsoft, Perplexity, and Google. They have all entered the AI health assistant space. And while tech giants making health announcements isn't exactly new, I do think that something feels genuinely different about this. We're not talking pilot programs or research previews. We are talking fully formed consumer-facing products which are designed to sit between patients and the health system. They're not saying they're part of the health system. They are aware that they are outside of it. And so they sit outside the health system to do things like answering medical questions, interpreting lab results, booking appointments, managing prescriptions, and connecting to your real healthcare records. Now, Perplexity has launched Perplexity Health, which connects to Apple Health, wearables, and electronic health records for over 1.7 million care providers in the US. Microsoft, they have introduced Copilot Health, which pulls data from over 50,000 hospitals in the US and explicitly describes its ambition as a path towards what it's calling medical superintelligence. Amazon, they have taken the health AI they built inside One Medical, and now they've put it directly into its shopping app, available to everyone in the US with an Amazon account. And then CVS, which is a big pharmacy chain in the US, they've partnered with Google Cloud to launch Health 100, which is an AI native open ecosystem health engagement platform powered by Gemini. Now, all the technology geeks, we love you, that listen to the show, you would know of William Gibson's famous quote that the future is already here, it's just not evenly distributed. Well, these AI health assistants, they do exist. And once again, I predict by the end of this year, they are going to have a significant impact on healthcare. We're going to see the health AI assistant as a persistent orchestrating layer, one that sits across your own health data, across your providers, your devices, and increasingly across your decisions as an individual. And I think the question is what role the formal health system plays now that they exist. And for Australia, where our regulatory frameworks and digital health infrastructure is still in catch-up mode for all of this, and many other jurisdictions are in the same boat, I think these questions have particular urgency. Now, George, these agents, they're not available yet in Australia, and I can honestly say this moment in history is maybe the first time I've ever wanted to be a consumer in the US health system. I want my data and I want to play with these tools. What are your thoughts, George?
Well, look, the last time we saw all the big tech companies pile into healthcare like this was back in the early 2000s when they decided that their part of the solution was the secret sauce that was going to make healthcare effective. So Cisco thought it was the network, Intel thought it was the processor, Microsoft thought just add Office to everything and away we go, and Oracle thought the database. And that didn't particularly end well. We saw some horrendous examples of solutions that had no problems they were solving. But things have moved on. We've had evolution thanks to things like cloud and some of the innovations there. We've seen Moore's laws kicked in. We've seen 100-time plus improvements in some of the infrastructure stuff. So now AI is the new hammer for every healthcare-related nail. And I think that's where we are now, that these the AI companies are coming in. Having said that, the discussion we had a couple of weeks ago around ChatGPT for health and Claude for health was very much a technology solution. This new crop has actually done something fairly interesting. So Amazon, for example, has paired the AI with their healthcare delivery arm. So it's more than just a chatbot. It's a chatbot which can actually get you a consultation and can organize a prescription. And they talk about managing the top 30 healthcare complaints. And that's interesting that it's becoming an integrated service. So the AI is part of a service, not just a cool tool. Google's working with CVS, one of the largest pharmacy providers. And if anyone's been to the US, their CVS is virtually on every corner. So that does give them a strong physical presence as well as our virtual presence. And again, they're looking at developing systems that integrate into that mold. We've seen lots of discussions here in Australia around the increasing role of pharmacy. I know the RACGP is not particularly happy about it, but the reality is the pharmacy in every corner that can take your symptoms, prescribe a drug, deliver it to you, throw in, you can buy your milk and bread at the same time and walk your way out is probably a very successful model for those sort of environments. Essentially, they all provide a very similar service. They look at your healthcare data, they throw it through their AI, it comes up with a whole bunch of recommendations or advice or just plain language descriptions. And from a consumer engagement and education perspective, that's really good. We've had lots of discussions on the podcast about how important consumer engagement is. The other thing that's really good about it is that it's something that can help improve health literacy. And we know that in and of itself is enough to improve the quality of healthcare in the country. They all claim to be able to access your existing health records, even if they're scattered across multiple providers. And that's a pretty bold claim. I don't know about if you remember, but last time Google tried that, our good friend ePatient Dave had a field day showing how inaccurate it was. Because again, the technology has moved on and things like FHIR are a big benefit, but the quality of record keeping is still outside their control. So aggregating poor data doesn't necessarily make it better data. It just makes it a bigger pool of poor data. So I think we need to still look at some of these things in reality. They claim they can make their information into action. Again, that sounds great. Making appointments and shuffling documents can be a pain. I've recently been trying to coordinate some care for one of my family members, and making multiple phone calls and making sure the right documents are in the right place is a pain. But the question has to remain, to whose advantage is the activity? Does it increase the number of services so you spend more in healthcare? Does it decrease the number of services so the insurer saves money? We still need to sort of understand how this works in the real life environment. And I think we're in very early days. I agree with you. It is exciting. If this does what it promises to do, then we are in a brand new world of healthcare where a lot of the barriers that are in there at the moment around collaboration, coordination can be relieved. They can be automated. And if we can automate some of those processes, that means healthcare providers can spend more time delivering healthcare. We also have to take into account that some of these AI tools are really improving at an amazing rate. So we basically may well have AI-powered healthcare system sooner than when we expect.
Oh, yeah.
There'll still be a clinician somewhere in the loop. Where in that loop is somewhere we need to think about. Now, a little side note, my wife and I have started watching the new Star Trek series, Starfleet Academy. And I don't know, you're not quite a Trekkie, but I've been a Trekkie for a long time. One of the characters in the new series is the emergency medical hologram, which first appeared in the Star Trek Voyager series in 1995. So the idea was that this spaceship was in the middle of nowhere. If they needed emergency help, they had an AI-powered hologram which provided the care. Now, he actually became quite a central character. In this new series, which is based 900 years after that series, this hologram has been in existence that whole time. So this is now an AI-powered medical tool that has 900 years of medical experience behind it.
Wow.
And there's some really interesting permutations of what it does. But that may well be that Star Trek is yet again highlighting the future for us. And that in the future, that may well be a holographic AI tool is really the tool that provides us healthcare. We'll find out in 900 years. So
wasn't there, what was the name of that technology, George, that they were doing demos at Silverchain in aged care a few years ago, and it was like a hologram? Was that Microsoft product?
That was Microsoft using the algorithm. Yeah. All these components that we've seen over the years all have value. The challenge has been getting them all to work together in such a way that they form a solution. And we are getting closer. We sometimes complain that healthcare moves very slowly, but realistically, over the last year or so, things have been moving so fast that it's really hard to keep up with what's happening.
Oh, yeah. Like, I'm so grateful we do a podcast because it forces me to actually try my best to be across what's going on. And it's a constant struggle because there is so much. These agents and the other Gen AI tools that we discussed at the start of the year, they're direct to consumer. So it doesn't matter what my hospital policy is, what my GP policy is. This is going to happen anyway. And who owns the assistant, at least in the current model? Who does it work for? It works for the patient. But let's say they work for the insurers in an American healthcare system, because agents should be able to get down that paperwork, that the medical billing process is so complicated in America and no one can make head or tail of it. And AI should be able to smooth all of that out. But of course, that would advantage the patient, but disadvantage the commercial model of like these things are purposely built to confuse us. I think we need to pay close attention to the business models that end up wrapping around these tools at the moment. Hey, it's free. It's great. Suck in your data and I'll be really helpful to you and I'll save you time. But we have to be careful that the business models around these things have a degree of ethics about them always. And it should be about improving care and improving the experience of care.
And this is where I think Australia can probably take a leading role, because we really should be looking at global collaboration around public healthcare type systems. We know that in America, there's a whole bunch of incentives and disincentives in place that are driven by financial concerns. But there's a whole bunch of countries, Europe, a lot of the Asian countries, Australia, where we do focus on patient care. And whilst we've heard complaints about our systems, I mean, they generally are better than most other systems around the world. And the Commonwealth Fund has highlighted that. This may be an opportunity for us to lead a global collaboration. So we look at how we use these tools in the context of a patient-centered quality healthcare system. And we know we have some of the world's best researchers here. We've had them on our podcast. I think we need to basically rethink that we don't necessarily need to follow what the Americans are doing, but we can learn from their experience. Interestingly, Charlotte's book is a great example of that patient enablement, and I think we need to take that into account. But then a recent article by Mustafa Suleiman, which looked at the fact that AI can appear to be very empathetic, but in reality, it's more a sycophantic type episode. So we need to take all those sort of things into account. And the business model, like I said, at the moment, it's very much a drug dealer model. We're going to give you lots of stuff for free until you get hooked on it. And then we're going to say, oh, by the way.
Yes, that's right. Yes. Yeah. And I think the best advice that George and I could give is that you need to be aware of these things, and we're doing our best to raise attention to these issues. You should talk to your colleagues at work, certainly talk to your bosses. If you're not having AI as a topic to discuss around your departmental meetings, certainly at board level and executive level, you really need to start doing this. You really need to raise the awareness, because these things are happening outside of the systems that traditional healthcare controls, but they will have a huge impact on it. So I really see all these tools are going to substantially shift the demand curve for healthcare and what that looks like. And we do not have much time to prepare our workforces for this. At the very least, we need to be starting to have these conversations. So yes, and we need to fix up our data as well. One, it needs to be digitalized, and also it needs to be readable. Like, you can't imagine what would, because this is going to happen this year. I'm absolutely convinced this will happen increasingly. Yes, as William said, the future is here. It's just not evenly distributed, but we're going to start hearing stories of more and more clinicians, GPs especially being that first point of call for many people, who are going to have a chat with their dermatologist, their GP, their physiotherapist, and they're going to say, oh, I bought a USB stick and I've got this great chatbot I'm using. So I just need like all of my health data, please. Could you just download it? Is that okay? And what are clinicians going to say to that? Because we're not even talking to clinicians to expect that, let alone having policies about how we do with it. Where's all the software vendors out there? Are you prepared to put a button on your thing, like click here to download? I'm simplifying it, of course. There's so much work that needs to happen to be even able to have a decent conversation with the consumer that asks for these things. So that concerns me that we're not having the conversations, but hopefully they are after listening to us, George.
So there was a good op-ed this weekend on Pulse from Sally Weissman from the HIMA.
Oh, yeah.
We're talking about the role of health information management. Again, these systems are only good as the data that's fed into them. So we really need to think more seriously about how we make sure the data in our systems is valuable data. We can fill it up with lots of free text and whatever, but how do we use that data? So I think that in itself was a very interesting article about there are new roles that we haven't taken into account. And then the other issue around equity, do those of us who have access to these tools get better healthcare than those of us who don't? How do we make these tools accessible? And that means that we need to improve not just the health literacy, but the digital literacy of the population and the availability of these tools. You might have seen an article this week in the press about some of the aged care facilities are charging extra for Wi-Fi or charging extra for those sort of things. Without those core technologies, you can't deliver on the promise of a lot of these tools. So we need to think about what is core requirement for us to be able to deliver on these services.
Yeah, absolutely. All right, George, let's go to our next topic. Consumer wearables. We have talked about progress with wearables a lot on the pod in our, almost 2-year history. But usually when we're talking about wearables, we usually have a lens of looking at them as like a supplement to clinical care. This story is about wearables as a research tool. We have spent a decade watching smartwatches creep towards clinical relevance, but they are usually used minimally in care around the world, despite some features being regulated and recognised as clinical grade. Now, in research, the data needs to be harmonised, compliant with research protocols, and be research grade. Well, that gap between what a smartwatch captures and what a pharma company or a regulator could actually use in a clinical study is closing. Verily, which is Google's precision health subsidiary, and Samsung, they have announced a partnership to integrate a Samsung smartwatch called Galaxy. They're going to take that data from the smartwatch and take it directly into Verily's platform, which will give pharma companies and government agencies an end-to-end system to deploy wearable devices in studies to collect patient data remotely and to analyze results. Researchers will get access to raw device signals, photoplethysmography. I'm going to go with that. It might not be exactly correct, pulse bodies, but if you don't know that word, it means technology that measures the blood volume changes in those microvascular tissues near the skin surface. So they're in most of our wearables these days. I'm not going to say it again, but those raw signals that come from that data, accelerometer and gyroscope data, They're granular streams that can be used to identify entirely new digital biomarkers. Now, this matters beyond pharma because if the infrastructure exists to turn a mass market consumer device into a continuous compliant data stream for clinical research, it literally changes what's possible in observational studies, post-market surveillance, and population health monitoring. So, George, we've been building towards this better real-world evidence capabilities for years. Do you think our health system is positioned to participate at this level with this kind of research?
Look, I think it's a very interesting question, but I'll start off with a little bit of history if I can. Many people probably don't realize that the first smartwatches that actually had health capabilities came from Australia.
I did not know that.
So
wow.
There was a company called Basis, which developed a very smart health tracker called the Basis B1 back in 2012. So well before the Apple Watch existed and any of the other smartwatches existed. And it was one of the first to be able to offer 24/7 continuous optical heart rate monitoring. It could monitor skin temperature. It could monitor perspiration. It was actually acquired 2 years later in 2014 by Intel, who were amazed by how great this technology was. And they took it and they did quite a bit of work with it. But of course, it was too early. It had some challenges. And unfortunately, in 2016, they discovered that they'd made it so powerful and it was doing such an amazing job that it was actually causing burns and blisters on people's hands from the processing involved. So one of the very smart watches to actually do health tracking was an Australian innovation. The guys who sold it to Intel did fairly well. It was a great tool. I actually had one back then. All the Intel staff got one until we got third-degree burns, so we had to hand them back. But just shows that this is going back now. That's 14 years. So this is a long history. Now, the consumable wearables are getting better. My Samsung Watch 7 now does things that even the Basis watch couldn't do. In between the Basis and my Watch 7, there was a company called Pebble, which launched a smartwatch via Kickstarter, which was one of the very early ones. So there's been lots of iterations. Lots of these comes around. Of course, the market changed dramatically when Apple jumped into the game because they added a lot of functionality. And to date, they've been really good at capturing information for personal use. We could always compare how many steps we had, how much sleep we had. We'd compare our pulse rates with our friends. They've made some interesting conversations, and my pulse is better than your pulse. But now we're talking about using this to capture data for clinical trials. And that's now a whole different, that's now making multi-million, if not billion-dollar decisions based on some of this data. And the reality is farmers tried this a couple of times and it's been hard work. But again, the technology has improved. The opportunities improved and the idea of how we use these things come around. So now, whether we will be able to use wearable data alone is a question. I think it's going to be part of a pool of data that we use in clinical trials, but it'll add value to the information and may well be able to use the smartwatch to synchronize the information across various areas. So the TGA and FDA will have to obviously look at that. The challenge at the moment is very much regulatory. At the moment, they have very specific requirements around the data that can be used in clinical trials. And we've seen the technologies move forward so quickly. So possibly the US may take a leading example here. But Robert Fitzgerald Kennedy Jr., when he became health secretary, said that he wanted every American to be wearing a smartwatch. That may be an opportunity for us to drive that initiative.
Yeah, I can literally see the American government paying for it.
Yeah. The interesting thing from a pharma perspective, and I've got friends and family involved in pharma, and that's a huge industry. So if they can use this information to speed that process to market, because at the moment, the biggest challenge with any new drug is the time it takes and the cost it takes to get it to market, and then the aftermarket surveillance. But the other interesting thing they're talking about here is the concept of digital biomarkers. I think that's something we really need to think about. We've looked at a number of digital biomarkers over the time, heart rate variability probably being the most obvious one. And this really takes us back to the old term, big data, the idea that we could capture all this data and then start looking for messages in the data. Now, there's a famous book by a guy called Nate Silver, The Signal and the Noise, and it talks about how we analyze big data sets to get information that's worthwhile. The first step in that is getting big data sets, and wearables give us an opportunity to develop those big data sets. Then we need the smart people to start thinking about what digital biomarkers are relevant. Because if they just tell us that our heart is beating, my smile on my face also gives that away. So I think we need to think about that sort of model. But if they start having predictive value, then we're actually starting to get into a whole brave new world. It's interesting times.
Yes. Well, to overshare, I got an Aura ring. I don't think I've mentioned it on the pod before, but I finally got one about 5 weeks ago. And I love it because of the data. Like, the ring is fine, but yeah, the app is really cool. But it's got to learn so much about you before it can start giving you insights. But one of the insights it gave me within 3 weeks, because I know I sleep very poorly and that's been well documented on this show. So I'm not learning anything about it, although I realize just how bad it is, because as a sleep debt, and my sleep debt over the last 2 weeks has gone up to 13 hours. So I don't think I'm ever getting that back. But what I did learn, which is a good thing, is when I'm like relaxing, watching television show or a movie, even out at the movies, my heart rate goes so low, my Aura thinks I'm asleep, because it prompts me and it's, at 9 p.m. last night, you took a 2-hour nap. And can I confirm that? And I'm like, no, I didn't. I was at the movies. Anyway, and it happens all the time. So when I do give myself permission to relax, I'm glad I can just like really wind down. I get to like 42 beats a minute. My heart rate really slows.
Your parasympathetic system kicking in over your sympathetic system, and very vagal nerve stimulation is the other big buzz at the moment. So maybe that slows your heart rate. These are correlations that we just didn't know beforehand. You never would have known that your pulse was 42 when you watched a movie. And what does that mean? That means that your nervous system is learning to relax. And it may well be that you need to watch more movies, Louise.
I'm happy that's the prescription that you're going to give me, George. Thank you. I will gladly follow that advice. But yeah, this is an interesting one. So I think it's a brand new day, really. And at the moment, it's just Verily and Samsung. But I think we'll see more and more of this. So it'll be a topic that we will come back to on the show time and again. All right, well, now time for a quick break, but when we return, we're going to be talking about what happens when the AI scribe gets a body and eyes, and we're going to zoom way out to discuss what might be the most extraordinary scientific achievement that we've covered on Pulse. Now, AI medical scribes have become, for many clinicians, the first genuinely useful AI tool in their daily work. The pitch is simple. The scribe listens, it transcribes and generates a clinical note, giving back time that was otherwise spent on documentation. Adoption has been rapid globally. Now, a paper just published in NPJ Digital Medicine by researchers from Flinders Uni and the University of South Australia offer a fascinating look. Now, what they did is they built a vision-enabled AI scribe using Google's Gemini model and Meta's Ray-Ban smart glasses to document medication histories, a task that requires both audio and visual input. They evaluated across 100 test recordings and over 2,000 data points. The vision-enabled scribe achieves 98% overall accuracy compared to 81% for the audio-only processing. The difference wasn't in what the AI heard, it was what it could see. So things like medication bottles, blister packs, labels. The improvement was driven primarily by reduced omissions, so 10 errors versus 358 in the audio-only condition. Now, when that paper came out at almost the same time, I was at an event that Heidi Health medical scribe threw last week here in Melbourne. Heidi is one of the most widely adopted AI scribes globally and an Australian success story. They made a very different kind of announcement. They unveiled something called Heidi Remote, which is a purpose-built lapel-style wearable device that records clinical consultations, audio only, with a single press of a button. It stores the encrypted audio locally on the device itself, and it runs on-device transcription. So you don't need a phone, you don't need an app or an internet connection to record these clinical consultations. And then it syncs up with the app when you're back online. It is the first dedicated hardware device from a clinical AI scribe vendor. And I think it signals something really significant, that the scribe is no longer just software, it's becoming infrastructure. So together, these two developments sketch a near future where AI in the room doesn't just listen, it might watch, it processes locally, it could capture everything. And the uses for something like the remote device that stores the conversation locally, I was thinking, George, like aged care, my friends in allied health that go school to school or home to home. So many uses where you're not just sitting in one spot with a desktop computer. So, George, I was at that Heidi launch, and listeners to the pod know that I like a good dance party, and I was going to go to see Faithless, but I couldn't because I was at the hackathon, and I'm really glad I went to the hackathon. It was better than the Faithless concert, I'm sure. But anyway, that concert was going to be at this cool warehouse to have this big rave. That's where Heidi had their launch event, and there could have easily been, I reckon, 600-800 people there.
If only they had invited Faithless as well, it would have been complete for you, wouldn't it?
Oh my God, it would have been full circle.
Look, it's interesting. They say we're starting to add new data sources to these things like the AI scribes. We had a discussion earlier around the holographic Star Trek Doctor. Well, these are the sort of building blocks that led us to that sort of thing evolving. And currently we only have audio-enabled AI scribes, but we see by adding vision, we significantly improve the accuracy and utility. So maybe later down the track, we can start adding things like feel and smell, and we can actually make a real AI doctor, because the discussion up to now has been that physical examination is something we can't do with software. But once you start adding hardware to it, it becomes a whole interesting thing. The oral history, and I've said this many times on the podcast, is very important. Most doctors pick up a lot from taking a good history, and AI scribes are a great tool in capturing that history information and putting it in context. But you also pick up things by looking at the patient. And I think this is where things are starting to really add value. Adding video to the audio here does improve the experience for the patient and the experience for the clinician. Now, but it does add some interesting privacy concerns, doesn't it? Because at the moment, if I tell you I have an itch in a private place, then you can, it'll end up in the AI scribe. But a photo of my itch in a private place may be a slightly more challenging privacy concern. So we need to think about those contexts. But again, more data, more processing power, better algorithms, improvements in AI. We're seeing a steady flow of innovation in this space at, like we said earlier, a much more rapid rate than what we're used to. The challenge we face now is, putting it all together. I think it's going to be really good, which brings us to the Heidi device. The reality is this concept of edge computing versus software as a service isn't a new idea. I remember talking about it a few years ago, but you putting it in the context of how we would use this in healthcare is really interesting. You pointed out a number of potential examples, but just the fact that we don't have to rely on the server being up, the network working, they can actually deliver care. That means if I'm in deepest, darkest Africa looking after a patient, that I can get the same quality of information there as I can in my Wi-Fi enabled clinic in Sydney. I think these are the sort of equity issues that we need to take into account. And also the fact that moves us away from reliances on big corporate data centers. I mean, these tools are now local tools. They may not be as good as the big data center tool, but as we saw in a lot of the disruptive innovation discussions over the last decades, good enough is sometimes better than nothing, and these are going to provide opportunities to do that. So I think it's, again, a very exciting development, and clinicians really need to rethink what their role is. We keep on hearing about the need for the clinician in the loop, the clinician-led initiatives, but the reality is, some of the things that clinicians do are going to be replaced, and we just need to come to grips with that.
Yes. And look, clinicians, they love the scribes. And we predicted at the start of last year that AI scribes were going to be the thing of 2025. And we were right, George. They definitely were. But they were already here at 2024. Last year, they really took off. So they're just everywhere now. And great to have an Australian success story as part of that journey. The pivot to the physical device, I wonder what the margins are on that type of product, because the business model around providing software is very different from hardware. And there are other microphone options that you could use, but then you'll need your phone with you. I was thinking about what you signal. So like expensive brands and the clothing you wear and what that signals to the market. And I was wondering, seeing this launch for Heidi Remote, and the CEO proudly got it out of his pocket and he put it on his shirt. And then I noticed some of the senior executives at Heidi were all wearing these things just to show them off. That will be part of the branding, because no one knows what the scribe is unless you're using it yourself. It's a piece of software. You're not looking at it as the patient, as other clinicians who might be in the vicinity. And all of a sudden, you're going to have a workforce of potentially, I'm sure Heidi would love it, hundreds of thousands of people walking around with a Heidi logo on their chest, attached to their scrubs or whatever they're wearing. And I was thinking that is a pretty genius move, because you've literally got a workforce out there using your device, signaling to their peers that, hey, I use this cool thing and I get to wear this. If they market it right, that could be a driver.
And the other challenge is that the scribe market is becoming a very crowded market. So this is a differentiator from Heidi. So if the Heidi tool differentiates itself from the hundreds of other scribes out there that are in the market, that gives them both a market opportunity and an opportunity to become the verb. Do we scribe or do we Heidi in the future? I mean, the same way we used to search and now we Google. I think that it's a smart move. I think it has great potential. It also does enable things that can't be done with the existing systems that require you to have all the infrastructure in place. A little lapel mic captures this information. So I think we'll be seeing a potentially revolution. And if they do start Heidiing, claim that I'm the first person to turn Heidi into a verb.
I love it, George. I'm sure the team from Heidi will as well. I know Simon listens to the show, and I'm sure other of the execs do. Yes, Heidiing. Let's see if it becomes a thing. All right, George, we've got one more topic to talk about today, and it is one that you highlighted for me, and I'm really glad you did. This is really exciting. So I promised everybody that our final hot topic, we would be zooming out, way out. Now, this might actually be the most quietly extraordinary scientific result we've covered on Pulse. We're talking about the biological fundamentals of life itself. Now, researchers at the University of Illinois have published a paper in Cell describing something most biologists considered decades away. For the first time, a team simulated the full workings of a bacterial cell. We're talking DNA, proteins, ribosomes, and other molecules, as it copies its DNA and divides into two. So not a model of part of a cell, but a whole cell simulated molecule by molecule, behaving the way a real-life cell would behave. This is a simulation. Now, the goal here wasn't just to build a digital replica, it's to understand how life actually emerges from these complex molecular interactions. And while, of course, this is still very early, it's early days for this research, it opens the door to a future where we can run experiments in silico, so testing drugs, understanding disease mechanisms, even predicting how cells will behave without needing to do everything in the lab. Because if you can simulate a cell, you can ask questions that have never been experimentally possible before. What happens to every molecule when you take this drug? What are the cascading effects of a single mutation? What does disease look like from the inside at that level of individual proteins? George, using computation to fundamentally understand life itself, what an amazing time we are living in.
This story really excited me. It's a really important story. And for a big data nerd like me, this is nirvana. I first did cell biology in 1979 as a first-year student. And I remember then just being astounded by the complexity of a single cell. Yeah, you had organelles within a cell which had very specific tasks. You had transfer RNA, messenger RNA, DNA. You had ribosomes which transfer things into protein. It was just amazing. And when you actually look at a single cell under an electron microscope, the complex beauty of them was astounding. You saw literally life in something 30 nanometers across that literally is the building block of every single life form on our planet and potentially in the universe. So we know a lot more about cells now. And reality is when we take a drug, it interacts with something in a cell. When we bump our arms, it's our cells that are bursting or the cells that are changing form, which cause bruises, which cause swelling. So cells are an integral part of how we understand the body. And the authors admit here that this is a very early step. This is a very simple bacterial cell. It only has 493 genes. Humans have several thousand genes in their cells. We're talking orders of magnitude here, but our early understanding of cells goes back to watching P cells replicate back in the 1800s when they were looking at how cells developed. This really has huge real-world implications for personalised medicine because we're talking about personalised medicine at a biochemical level, at a level that is layers beyond below what we're used to. And we've talked about digital twins in the past, but digital twins take up a whole new meaning when we start talking about simulations at the cellular level. Now, first of all, before people get too excited, don't get too excited. This is a single cell followed for about 120 hours. The human body comprises about 30 trillion cells. Simulating all 30 trillion at once is a pretty big task. And
but quantum computing is on its way, George.
That's right. And the reality is, at the moment, to do that, we would probably need our own data centers. But we all know that Moore's law is our friend, and that's improving dramatically. So I think this is a story that we need to keep watching. Leroy Hood talked about system biology a decade or so ago, well before the technology was available. This, to me, is probably the first step in that journey. So I think it potentially may be the thing that changes the whole way we deliver healthcare in the future. In particular, things like oncology, which is a malformation of cellular physiology. If we have a better understanding of how cells work, maybe that gives an opportunity to find new and exciting treatments for things like cancer, things like heart disease. There's just so many opportunities that it opens up.
Thank you, George, for explaining it so well. I really look forward to seeing what the developments are in this space. And yeah, like the idea that we could do personalised medicine at the cellular level, that's mind-blowing. It's so special. So congratulations to the researchers.
Yep, we'll be keeping an eye on that one.
Yeah. All right, George, that is a wrap for our hot topics today. Did you have any recommendations for the Pulse Potties?
I've mentioned the emergency medical hologram so many times. I think people should go and watch
Star Trek, yes.
Star Trek, Space Academy, and if you get a chance, Star Trek Voyager. And that may well be, we've all heard about the tricorder story, yet another Star Trek innovation. So maybe Spock and Kirk may well be our heroes in the future.
Yeah. Electric doors, they were from Star Trek, weren't they?
Absolutely,
no one thought about a door that would open like from movement until someone's invented it to Star Trek, and then it became a real life thing.
There were some people who suggested that Gene Roddenberry was actually an alien planted on Earth to introduce these new technologies. So, yeah, I won't go down that pathway, but yeah, there's lots of interesting things that are in science fiction. Again, it's one of the advantages of things like science fiction. Sure, 75% of it may be futuristic rubbish, but sometimes there's some interesting stuff. There's actually a book out called The Science of Star Trek, which I can recommend as well. It actually goes into some of the science and some of the stuff in Star Trek probably is totally fictional, but then again, quantum computing was totally fictional 50 years ago as well.
Yep. And actually, Guy from Evidently, who we had on the show recently, he sent me a picture because he wanted to know how the episode landed and stuff. And I was like, no, it went well. And he was at a place that has a quantum computer and he took a picture because he's, what do you think that is? I'm like, I don't know, it's like a server rack or something. It's like really big. And he's like, yeah, it's a quantum computer. I was like, holy shit. That's pretty cool.
We're an interesting time. What about you, Louise? Anything you recommend for our listeners?
Oh, I do have a recommendation. I will put a link to this in the show notes. So there is a group of researchers, and this is a global consortium, and they're looking to build the Health Chatbot Users Guide. So rather than sitting around waiting for governments, and we always talk about this topic on the show, George, like people need guidance. They're going to be using these tools and it's moving fast. How do we critique it? How do we know that it's giving us good advice? All of that sort of stuff. A group of academics from multiple countries, Australia's in the mix, UK is leading it, Switzerland, the US, and there's heaps of countries involved. They're building a chatbot user guide for patients, and there is currently an expression of interest. They're recruiting collaborators. So if you want to know more, check out the show notes. We'll provide a link to the website, and they've also published a paper about this in Nature Health, which is where I found it. That's a great initiative. Thank you to all the academics that are leading that work. Really important stuff, and we want to help promote that and platform that work.
Charlotte believes, doesn't it? She's actively involved in that project.
Oh, yeah, Charlotte's there. Yep.
Yeah. It's good seeing the sector take a leading role rather than waiting for government to tell us what we can do.
Yes, it's too important to wait, and I think governments are just taking too long on this stuff. They really should be out there already. It's up to the Pulse Potties to work out what we can do to lead and to make sure we all have agency in this brave new world.
Government's defence, they do have a few things on their plate at the moment.
I get it. They're busy and I get it. Yes. All right. George, thank you very much for joining me in the studio today. Always a pleasure. Great to have this extended edition of Hot Topics with you. If you could please read us out.
Yeah, thanks, Liz. It was always lots of fun as well. I look forward to these. Thank you all for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Emily Mara for her support. Big thanks to everyone for listening. Make sure you subscribe, follow, and rate us wherever you get your podcasts. Visit pulseit.news to catch up on the news from Australia, New Zealand, and Ireland. Send any feedback or topic suggestions to pulsepod@pulseit.news. We'd love to hear what's on your mind.